Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Hello, for those of you who don't know me, my name is Nicole Ehrhardt. I'm one of the adult endocrinologists at the University of Washington Diabetes Institute. I'm a recent transplant from Washington, D.C., and I gave the last lecture last week that was on diabetes medications type 1, which we focused on our older medications, and today we're going to talk a little bit more on our type 2 diabetes medications, our newer diabetes medications. We're going to take a look at them in the setting of trying to individualize them for use with HIV. So first, my disclosures. I've received a consulting fee from Novo Nordisk, and I've received investigator-initiated grants from Dexcom, which is a medical device company. And then my own echo is sponsored by educational grants from Merck and Novo Nordisk. So today, what are we going to do? We're going to basically take a look at all the newer diabetes medications, and we're going to really try to understand the physiology, the mechanism of action, managing the side effects, the dosing and administration of the individual drugs. We're going to really also take a look at how we use them in liver disease and chronic kidney disease, since so many patients living with HIV have those comorbidities. And then we're really going to focus on today, the use maybe outside of glycemic management for a potential cardiac and renal benefit with these newer medications. So just like I showed last time, what we really want to do when we're individualizing medications for our patients living with diabetes is to keep all these things as a running thing in our head so we best choose the medications for them. So if you know the mechanism of action, you're going to be able to answer a lot of the other questions that will come up about the medications. But, we really do want to know the efficacy of the medication. We want to know if it increases the risk for a serious side effect or complication like developing hypoglycemia. We want to know the common side effects so that we can counsel patients on them so they don't stop the medication too abruptly without getting used to the medication. We want to make them aware of the potential for serious but rare side effects, so again, they feel comfortable starting the medication. We want to talk about it from terms of weight loss, weight gain perspective. And then we really want to look at it, is there any cardiac benefit in some of these newer medications? How can we use them in liver disease? And then in chronic renal disease, how do we utilize these medications, and is there any renal protective effect? So I showed this slide again last time for our first lecture, but again, this is an overwhelming slide because it shows very clearly that we think about metformin, but then we have all these classes of medications that are available for our diabetes management. And one of the most important things we're now supposed to be thinking about is outside of glycemic management, should we be using this medication in those that are high cardiovascular risk or who have renal disease already? So how did this all start, this idea of cardiovascular benefit or risk with our diabetes medications? Well, in 2007, I don't know if you remember this, a New England Journal of Medicine article came out that basically said that potentially this medication called rosiglitazone in the class of the TZDs increased cardiac risk or cardiac events. And so after that study came out, that's when all the rest of the medications and the new medications in the pipeline started to be requiring cardiovascular safety trials. And so this is just sort of a summary slide of all the cardiovascular safety trials that were done on the newer classes of medications. We will highlight that RECORD was adjudicated the Pioglitazone and TZD class of medications, but it came too late and rosiglitazone was already pulled from the market from that. So even though we're going to be talking about newer medications, I do start this lecture with our older class of medication, the thiazolidinediones or TZDs, just because that was sort of where this idea of looking at cardiovascular risk or benefits stem from. So to think about our TZDs, how do they work? So they increase insulin sensitivity. And it's a variety of mechanisms of actions, and we're not going to go into detail about that. But what I will tell you is that I was a fellow in 2007, and yes, when we had to take people off of this class of medications because that report came out, we did see a lot of people who needed much more insulin than they were on previously. And then, it is a very good medication. The efficacy is about 1%. I did have patients when we had to pull them off the medication that then required insulin. So think about it as an insulin sensitizer, and that's why we really like it. And because it just sensitizes for insulin, it has a low risk for hypoglycemia. So that's why we also like it, okay? But Similar to some of the newer diabetes medications that we're going to be talking about, one of the limitations and barriers is, effectively talking about the risk-benefit of these medications and the common side effects so that we get them to utilize them. So what don't we like about the TZDs? Well, they do cause a bit of weight gain, so they're not weight neutral. People do have several pounds of weight gain from the medication. One of the most common side effects is that you can get increased risk for lower extremity edema, sort of similar to our calcium channel blockers. So you do want to make people aware that leg swelling is a common side effect of this medication. It is contraindicated in class 3 CHF or higher, so uncontrolled heart failure. And it has not been shown to increase heart failure risk, but there is this possible increased risk. As well, we do have to remember that it does decrease the bone density and there is some potential risk for increased fracture as we age. Sometimes, because our patients tend to be a little more obese, they are more protective, but in our leaner type 2 diabetes, that might be more of an issue. And then there's rare case reports of increasing the risk of macular edema, so be aware of that and don't use it in that population of your patients. And then there's this questionable risk as well as could it increase the bladder cancer risk? Again, you simply would not use this medication in someone who had a strong family history of bladder cancer or personal history of it, but there's maybe a slight possible risk associated with that. So, it's hard when you see that list of all the side effects or things that you have to counsel patients on them to think, well, when do I want to use this medication? Well, I think this study highlights potentially a population you'd want to at least consider it in. So one thing I'll highlight about the IRIS study is that you didn't have to have diabetes to be enrolled in it. You just had to have insulin resistance. But after a TIA or cardiovascular event, they found that if you added Pioglitazone, you actually had a decreased event rate. And it was pretty clear that it definitely improved it with a relative risk reduction of over 24%. And so, again, in those patients who've had a cardiovascular event, Pioglitazone may be protective to them. The other thing we want to think about it, especially because a lot of our HIV patients have a comorbid liver disease, is what about its effect in the NASH population? So this class of medication was actually the only class of medication that has shown benefit from a fibrosis benefit for NASH patients. And so the other population of patients that might truly benefit from this medication are those that are developing cirrhosis and fibrosis from their NASH, okay? So again, those two particular populations may definitely benefit. And so, my summary of the TZDs. So we know it helps target insulin resistance. So a lot of times if I have people on really high insulin doses, I do think about using it as an insulin sensitizer. Particularly to the Pioglitazone, there is some mild cholesterol beneficial effects. So it is beneficial in that population as well. Definitely some fibrosis benefit in NASH, and our only medication right now that have shown improvement in fibrosis scores. In those with established coronary cerebral vascular events, potentially some benefit. The limitations are the weight gain, the leg swelling, and the potential risk for fractures, and not to use it in those that have uncontrolled congestive heart failure. So this is a medication you use in a very select population. And then, because it's an insulin sensitizer, there was studies looking at it to help with the lipoatrophy that I control in HIV, but they actually showed no benefit. And so again, particularly to the HIV population, that wouldn't be necessarily a reason to initiate it, but definitely in those that have some degree of liver involvement or in those that have already had a cardiovascular event, there may be some benefit. So what about next, our newer class of medication? So our first one we're going to talk about is our Glucagon-Like peptide 1 receptor agonist, or GLP-1 receptor agonist. And again, what I'll highlight here is when we're talking about starting injectables, we're typically talking about insulin. But here, in the newest guidelines, the ADA actually recommended when you're talking about starting the first injectable, they say consider a GLP-1 receptor agonist. If you remember from the last lecture, we sort of highlighted that we don't want to not initiate insulin. So remember, a GLP-1 receptor agonist would not be appropriate to use if they have evidence of symptomatic hyperglycemia, so weight loss, cachexia, significant polyuria, polydipsia. You'd want to initiate insulin to get them out of that glucose toxicity, but then what you really want to do is, after a month or so, think about once their glucose improves, decreasing the insulin and adding on a GLP-1 receptor agonist with the goal of perhaps replacing it because of some of the beneficial effects we're going to talk about now. So how does a GLP-1 receptor agonist work? So basically, as we sort of talked about with the DTP4 inhibitors, what this one is that it actually mimics the GLP-1. And what does GLP-1 do? It causes us to release insulin in a dependent manner in response to food, so that's good. It slows gastric emptying, so it makes us feel less full. And then it promotes satiety, like acting centrally in mechanisms that we're still trying to understand. It also does suppress glucagon. So because of all those effects, what do we like about it? Well, it has a really high efficacy. Our newest strength of the medications actually will have an up to 1.9% lowering of A1C. And it also promotes weight loss, usually somewhere between 8 to 12 pounds on average based on the different medications within the class. And we like it because even though it does suppress glucagon, you really don't have a high risk for having a hypoglycemic episode with this medication. So for all those reasons, it has become a medication to think about and individualize for our patients. So we're going to go into a little bit more like some of the limitations or what I say barriers to starting this medication, right? Because just like the TZDs, there is a longer discussion you have to have with the patient about the common and serious side effects. And then also you want to make them comfortable using a potential injectable device because many people will equate GLP-1 receptor agonists with insulin. So that's usually actually the first thing I say. This is not insulin, okay? And then I tell them that there are daily injections, but many of the newer forms of these are weekly, so the injections are minimized, okay? But the most common side effect that you really want to let people know about is that usually people will feel some degree of nausea when they start the medication. Some will have none, some will have just a little bit of nausea, and some will have nausea to the point of vomiting. And what I tell people is that we'll go over the dosing, but when you start the medication, typically we start it at a low dose and then we escalate it based on the nausea profile or lack of nausea profile. And so what I tell people is that even if you feel really terrible after that first dose of the GLP-1, take the second dose because most people will actually feel significantly better and have milder symptoms after that second dose. If after 2 weeks on the lowest dose of whichever GLP-1 receptor agonist you choose, you're still feeling significant nausea and vomiting, then it probably isn't the right medication for you. The other thing that I'm commonly asked is, well, do you give anti-nausea medications in this period? And I actually say no because we don't want to mask the side effect of the medication and so that we extend the use of the medication to someone who's truly intolerant to it. So I do not tend to give anti-nausea medications when I start this medication. Number two, the other thing I found is that in people who have reflux, because it slows down the gut a lot, you want to ask them if they have any history of GERD or reflux and make sure they're taking their proton pump inhibitor. It looks like there's 2 chats. Let me stop for a second. So we're going to go, the one question was about oral versus injectable, and we'll go over that in some of the next slide. And then there was a little thing saying that we have just started a diabetes echo. And so we will be moving forward with that. We just did our first session for that. So we can definitely provide you with information how to join in on the diabetes echo specifically. So we were saying that if a person has reflux, you definitely want to make sure they're taking their proton pump inhibitor. And if they're sort of stable on once a day, a lot of times I'll escalate it to twice a day, just sort of prophylactically for the first 2 weeks on their therapy, or definitely if they haven't been taking it in a while, I'll do 2 to 4 weeks of doing it twice a day and then de-escalate it back to once a day. And I find that a lot of the GI side effects are much more tolerated if we empirically, are treating their GERD because it can worsen it. The other thing I found in people who have really severe symptoms and a history of GERD, I have started to screen those populations for H. pylori in the stool. And I have been able to, when I found a positive result, once you treat it, I have been able to do a retrial with some success in patients. So that's my little pearls on the nausea and how to mitigate the side effect profile. Now, we talked about the common side effects, but what people will see on the TV or read on the label and then cause them not to start is this possible risk for pancreatitis, okay? Because that's a serious but rare side effect. So how I counsel patients is I say something like, we know your diabetes, which is not controlled right now, can hurt your eyes, your feet, your heart. However, every medication has a risk. And so the risk of this medication is you have a 1% to 2% increased risk for developing a pancreatitis. Now, anyone can develop a pancreatitis, but you have a 1% to 2% increased risk. And actually, when you look at the meta-analysis on pancreatitis, a more recent one that came out did not show an increased risk with GLP-1 receptor agonists. Sometimes it can increase the risk for gallstones, so I think that's probably where the slight increased risk for pancreatitis stems from. And then the other thing that there's a black box warning about is this potential risk for increase of C-cell hyperplasia, but only in rodents models. So I just tell people, you know how things are studied in rats or rodents before it goes to human trials? Well, what they found only in the rat data was that there was a slight increased risk for C-cell hyperplasia, which can be associated with this rare type of thyroid cancer called medullary thyroid cancer. Now, this class of medication has been around for over 15 years at this point, and we haven't seen any human increased incidence of medullary thyroid cancer, but because of the theoretical risk, we do want to make you aware of it. And again, only you can decide the risk-benefit, but we know this medication is going to be very good for you for your diabetes. And then we already sort of talked about how to talk about it as not an insulin project, and we definitely think that it's less of a barrier of injection when it's once a week. And so these are all the different GLP-1 receptor agonists that are available. And, you will have access to my slides after, so you can sort of look at them in detail. This article is actually a very nice review article on GLP-1 receptor agonists if you're interested. I'm just going to highlight on this slide, there are mixed GLP-1 with basal insulins. And I'll just be honest, this is my personal opinion. I don't use the basal insulin mixed with GLP-1 receptor agonists because we're trying to promote weight loss and other good things from the GLP-1 receptor agonists, and we want to maximize the GLP-1 receptor agonist and minimize the basal insulin if possible. So I tend to keep them separate, especially now that the once a week injections are due. It doesn't increase the injection burden on someone who's only doing one additional injection a week. But that's just a personal opinion of mine. Someone just chatted something else new. So someone had a question about Saxenda for weight loss, history of diabetes on, I guess that's long-term insulin. Victoza 1.8 is tolerating well. We discontinued Victoza and initiated Saxenda 3 milligrams at a higher dose, A1C at 6.1. So what I'll tell you is, yes, LIRA-RENAL is both Victoza and the diabetes dose is 1.8 milligram. Saxenda, which is approved for weight loss itself, is 3 milligram, is also LIRA-RENAL. What I will tell you is that coverage for weight loss medication has been very slim in my experience. And so every few months, I'll try to order LIRA-RENAL at 3 milligrams for a patient. And I haven't had that much success, but there is a website that you can type in the patient information and you can find out if it's covered or not. But yes, you do get a good weight loss response from using the LIRA-RENAL at 3 milligrams. And we're actually going to talk about weight loss on the other diabetes medications, in the next slide. But that's a great question. I just have not found great coverage, because it is a fairly expensive medication. And so a lot of times we as endocrinologists choose GLP-1 receptor agonists for the weight loss potential, but use them at the diabetes medications dose because that's what we have available for the patient. So the reason I'm highlighting these three medications is that when you look at the different formularies, they're probably the most commonly available based on the US formulary. So we're going to go over Victoza, which is LIRA-RENAL, Trulicity, which is deglutide, and Ozempic, semaglutide in a little more detail. I guess my first question is do people know how to dose it and escalate it? Do people feel comfortable with that? How much are you actually using these products? Anyone want to chat to me? Anything? More often now. I use it frequently. Great. So I will just go over in brief then. Typically, like we said, what you do with the LIRA-RENAL is you would start at the 0.6 milligram daily, and every 2 to 4 weeks, based on the nausea profile, you would escalate it up to 1.2 and then 1.8 milligrams. One thing I like about the Victoza, and people who have a lot of GI distress, because it's not official, so this is unofficially, what you can do is you can click a certain number of clicks to go in between the two doses. So you can start at approximately 0.3 milligrams for people who have more stomach or GI upset, and then it's only a 24-hour medication. So that's when I still am using liraglutide if it is the preferred one by the patient's insurance and you have to try and fail that one first. Or if I really want to start at a baby dose of the medication, just make sure they're tolerant to it and then escalate it further. So that's, maybe one teaching pearl about the liraglutide that you could utilize. And then, what do we like about the Trulicity or the deglutide? Well, you just click it and you put it on your stomach and you push the button and you never see a needle. So many people like it because you never see a needle. So it's very good for patients who have some trepidation about needles. And you started at 0.75 milligrams, and then after 2 to 4 weeks based on the nausea profile, I typically escalate it to 1.5 milligrams. And then the other thing that we will throw out is just in the last few months, deglutide has been approved for use at higher doses for our diabetes and then also for the higher weight loss potential. So most recently it's been available at a dose of 3 milligrams and 4.5 milligrams. And that's actually, remember how I said up to a 1.9% A1C lowering? Well, that is actually the average A1C lowering in the 4.5 milligram dose. And then the average weight loss dose is about 10 pounds. Liraglutide has about 8 pounds. So again, at the highest dose of Trulicity or deglutide, you get about 10 pounds of weight loss and up to a 1.9% A1C lowering. Remember, everything is always skewed on where the A1C starts at baseline. So, people tend to get a little bit more bang for their buck if they're higher at the baseline. So good question about the deglutide. Yes, all of the forms of deglutide have a hidden needle. So my next slide is going to actually show what is the preferred GLP-1 for the Medicaid derivative, which I know is a lot of our population. We are seeing more access for these things for our Medicare population, but it all depends on the copay because as we know, these are very expensive medications. We were just looking at this. When it's formulary, they're not specifying the dose. And so I will be quite frank, since I've been here, I used to do a lot of weight management back in DC, but I'm seeing a lot of the post-transplant patients here. So I haven't been able to utilize the newest dose of the deglutide yet because I don't have as many patients that I would consider candidates for it at the time. But my understanding is commercially it is being covered at the 3 and 4.5 milligram doses for patients with diabetes, and then we'll go into the Medicaid issue on the next slide. So the last one to think about is our semaglutide or Ozempic. And this one, you start at 0.25, and typically on a monthly basis, you will increase it. Now, one thing to mention about the semaglutide that you need to counsel your patients about is that in patients with baseline retinopathy, it may slightly increase the risk of worsening retinopathy. But it's actually for a good reason, right? Before the 4.5 milligram dose came out, it was the most powerful A1C lowering. So that's the one that goes down by about 1.6%. So the thought process is that because it's such a strong medication, you got a too rapid decline of your blood sugars, and that's what, as we know, can worsen initial retinopathy, and then you get improvement, okay, when you get improved glycemic control. So in this particular case, if someone's A1C is above 9, I wouldn't want their blood sugars to suddenly be 100. So you go up by 0.25, then 0.5, then 1, on a monthly basis, maybe then every 2 weeks, just to make sure you don't get too rapid decline of your blood sugar, if that makes sense. But the reason we, in general, endocrinologists have been preferentiating semaglutide is because of that higher A1C lowering up to 1.6%. And then also it tends to have the largest weight loss potential up to 12 pounds with the 1 milligram dosing. And then, so right now, I just pulled Molina Healthcare, and our oldest class of our GLP-1 receptor agonists, and it's a good medication. I use this a lot when it was the only weekly injection that was due, is Exenatide or Bydureon. So the original product that was available was Byetta or Exenatide, but it was short acting, and you had to dose it with the first and the last meal out of the day, and you had to dose it 30 to 40 minutes before the meal to get an appetite suppression. But it was a good medication too, and that was all that was available for A1C and weight loss. But typically now what is covered is the Bydureon pen that is once a week. It comes only in 2 milligrams, so there's no dose escalation. And it does take about a month to see the full effect. So, you don't see that much effect at 0.25 of the semaglutide or 0.75 of the glutide or, 0.6 of the liraglutide. But this one, even though you start at the complete dose, it tends to build in the system. So you'll see more effect from the glycemic control at about a month. So don't get discouraged if you don't see the results immediately. But I'm showing you, there's 2 different versions. There's the pen that you just turn and click and is much easier. Unfortunately, Medicaid is not covering that one either. So we usually have our nursing staff demonstrate the Bydureon pen because it's like, you have to shake it and tap it and do a bunch of turning things. It's not terrible, but there is 3 or 4 steps associated with it for it to work effectively. And so, in this link I've shown you, we often give people YouTube videos of it, and it's available both in Spanish and English. So the final thing about the Bydureon that you should let people know about is that you can get subcutaneous nodules at the injection site. It is the biggest needle out of the GLP-1 injectables. And you do want to tell people that they're benign, they go away, but they can be there for like a month or 2. And so to make people aware. And just to let you know, like when I first started using this medication, I didn't let someone know about it. And unbeknownst to me, he went to a surgeon and had 3 or 4 of these things surgically removed. So had a surgical procedure, with a benign thing that would have self-resolved over time. So I do now make sure that I tell all my patients about this. So the other thing is remember, if you start off with Bydureon, and a lot of times Victoza is the other preferentiated one, so in the Medicaid derivatives, but I find it hard to do a daily injection, so I usually show both the liraglutide pen to my Medicaid patients and the Bydureon pen and give them the choice. Most people tend to choose the once a week injection, even though it's a bigger needle and several more steps, but it would be by patient preference. And then remember, I have a low threshold after a month or 2 if they're forgetting to take the daily injection, if they develop skin nodules, if they feel like they can't do the dosing on the Bydureon. I then put in a prior authorization, and then typically the glutide or the semaglutide will be covered. So they're pretty good about covering it with a prior authorization as long as you've tried their initial preferred one. So that's my sort of teaching about that as well. And then there was a question in the chat about the oral semaglutide. So that's called Rybelsus, and that became available. And there are some things we want to know about the Rybelsus, okay? It is in a blister pack, so this is not something that you can take out and put in your pill box because sun exposure does affect its absorption, okay? So don't take it out of the blister pack. Then number 2, it must be taken on an empty stomach, and they actually very specify a small amount of water, no more than 4 ounces, and then you're going to get the best absorption if you wait 30 minutes after taking it, and then you eat food. So again, it's a little more complicated. It's great because it's oral. It has about the same A1C lowering as the liraglutide, which is about 1.1%, so good efficacy. It comes in 3, 7, and 14 milligram dosing. So, again, you escalate it based on the nausea profile. The weight loss is about the same as the liraglutide as well, like 8 pounds, so a little less than the glutide and the semaglutide. But in general, it's a good medication to use. I will tell you that I have a few patients that I've put on the oral semaglutide, but I tend to preference using the injectables for the most A1C lowering and the most weight loss potential. So I don't use it as much, but it is a very good medication. And I think someone also had a chat. Oh, so the question was about Rybelsus being taken with the levothyroxine. I would not take them together. Now, I often tell people if they're having problems with their morning medications to take levothyroxine at bedtime, okay? Because it's like long half-life, 7 to 10 days. And so remember, levothyroxine is a forgiving medication. I always tell patients that's the medication to get a pill box for, because if you forget it, you can actually take double the dose the next day because it's a cumulative dose. And there was a study looking at our patients with barriers to taking our medications where they gave all 7 tablets of the levothyroxine once a week, and they actually showed a pretty good steady state. So, but I try to do not within 4 hours of other medications and 2 hours of food. And if they're having different numbers, it's always the question is how well they're absorbing it. So then I might even say not within 4 hours of food for the levothyroxine. Very good question there. So what about the use of GLP-1 receptor agonists in chronic kidney disease? So we'll just say that in general, because of the mechanism of action, you don't have to reduce the dose of the GLP-1 receptor agonists in chronic kidney disease, except for the Byetta, that original Exenatide, which I don't think anyone is really using anymore. But what about the data in stage 4 and stage 5 kidney disease? So there's very limited data. But what about GFR less than 45? So definitely that's, something to consider. This was the LIRA-RENAL study, and they did look at people who had GFRs of 30 to 45, and they found that it was tolerated and had good efficacy, okay? There was maybe a slightly higher nausea profile associated with it, but it did show that it was safe to use in lower GFRs. And how do I use it in my practice? I definitely initiate it in people who have GFRs in the 30s to 45 as long as they're stable and there's no rapidly changing. We have to weigh that against the slight risk of getting them dehydrated if they have nausea and vomiting. But because of the other beneficial effects we're going to talk about, I typically will use it down in the lower renal function. Now, in people who've been on liraglutide, sometimes I will continue it until the GFR is down to like 15, as long as they're tolerating it from a nausea perspective, just because the alternative is insulin after that. I wouldn't necessarily initiate a GLP-1 receptor agonist with a GFR of less than 30, and I'd probably preferentiate using, at least initially to make sure the nausea profile wasn't great, a daily one rather than a weekly one. But I am using these in people who have chronic kidney disease, and I think that's a clinical pearl to be comfortable utilizing them in the lower GFRs, because there is some data that these GLP-1 receptor agonists may have some beneficial renal effect. And then why do we really love the GLP-1 receptor agonists outside of the weight loss, the low risk for hypoglycemia, and it being fairly convenient as a weekly medication? So someone asked me about it in NASH patients. We're going to go over the data. They just had a new study, recent results come out. But let's first talk about why, we should be thinking about them based on their cardiovascular profile as well. So these are 4 of the main studies that looked at from a cardiovascular benefit effect. And, as we know from studies, the first thing we have to do is sort of look at the population they're targeting. The liraglutide and semaglutide study, they were more preferential as secondary prevention, meaning they were people who'd already had a cardiac event or were at very high risk. Now, REWIND, which was our deglutide study, actually was as a primary prevention, meaning that, for the first cardiovascular event. And what did they see? They all showed benefit. And as well, the nice thing about the deglutide is they were less uncontrolled than some of the other studies. So even in people who had not yet had an event but were at risk, and with a tighter A1C control, they showed cardiovascular benefit. So that's why we really like these medications. So this is sort of a summary of, yes, they have cardiovascular benefits. Yes, they have potential renal benefits. And so, we do want to think about utilizing them as our first injectable and honestly as a second-line agent after metformin, especially in those patients that are very uncontrolled because they have some of our strongest A1C lowering. So what about the GLP-1 receptor agonist and liver disease? So they've started to look at it more in the NASH patients. But this was a little bit disappointing because this was the recent study that came out in semaglutide, and what they found was that the NASH resolution or no worsening of fibrosis in 59% versus 17%. But what didn't reach statistical significance was improvement in the fibrosis stage. So, going back to the glitazones where you actually saw improvement in fibrosis, this showed benefit from the NASH and no worsening of the fibrosis, but did not make it to improvement of fibrosis. And again, we're going to gather more data, I think, on the GLP-1 receptor agonist and its benefit, particularly in NASH. So that will be an ongoing discussion. But I agree, definitely I'm thinking about its use in patients that have LFT abnormalities and either had diagnosis of RNAS or in my diabetes patients that, we think since they have a high likelihood as well to have it. So definitely that would be a reason that I would preference using it. So our summary of the GLP-1 receptor agonist, the first thing I have to highlight is that I do want our children to have health care, and it is an expensive medication. It's about $800 on average a month. But what I tell people is that, well, I don't know how you can weigh that against, one hospitalization for a heart attack is probably $50,000. So as well, what I feel like is my goal is for everyone to be diet controlled or metformin controlled. And so if you give them a tool that helps promote weight loss, in addition to talking to them about small changes, I definitely have seen 20, 30 pounds of weight loss from patients that are on a GLP-1 receptor agonist. And honestly, that's when I may hold the GLP-1 receptor agonist and work with them on their lifestyle so they don't have to be on an indefinite medication if that is their desire. Versus, in someone who has ongoing cardiovascular disease, then maybe even outside of A1C control, I would continue it for that reason. So it's always individualizing things for the patients, But we do it does work. It is a very strong A1C lowering medication. We do think the weekly dosing probably lessens the barriers to taking the medication. It's a low risk for hypoglycemia. We do have that oral version available. I do think you have to be pretty precise on how you take it, so I would use that in a select population. Nausea is the main side effect. And then I definitely would consider uncompensated cirrhosis, especially in our NASH patients, given that data that we just presented. So then going on to our final class of our medications, our sodium glucose cotransporter inhibitors, okay? And how do they work? Well, they just cause you to pee out glucose in your urine, right? So why do we like that? Well, because you're peeing out nutrients, you tend to have a little bit of weight loss associated with the medication, on average about 6 pounds. As well, because you are only peeing out excess glucose when you reach the set point of above 180, because that's usually when you start to diurese, you have a low risk for hypoglycemia associated with this medication. Of course, there's always that risk if you're using it in sulfonylureas and basal insulin, a slight increased risk. And then we'll talk about the renal and cardiac benefits shortly. But again, one thing I do want to highlight about this medication and why I probably haven't been using it as much is most of my patients I see, I feel like always have come to me uncontrolled with A1Cs over 10, right? So it is a weaker agent than the GLP-1 receptor agonist, usually less than 1% change in A1C associated with it. But now we're going to talk about it as a whole picture and why I'm trying to think about using it more in my clinical practice because of all the benefits that have come out, okay? So just like the GLP-1s and the TZDs, there's a laundry list of things you want to discuss with your patient about potential side effects of the medication. And, the main one is because you're peeing out, nutrients, there is this potential risk for UTIs and mycotic infections. There has been case reports of Fournier gangrene associated with sodium glucose cotransporter inhibitors. You want to counsel the person to continue to drink water and to worry a little bit about, dehydration, and you can have some rise in creatinine acutely if they're not drinking enough and get orthostatic and dehydrated. We're going to talk a little bit more about this rare but serious side effect of euglycemic DKA. And then originally Dapagliflozin carried a risk for bladder cancer, but they actually recently removed that warning from the label. So I just wanted to highlight that because that has come out, I think, in the last 6 or 9 months at this point. And then specifically more so for Canagliflozin, there may be an increased risk for fracture and then an increased risk for amputation. And we'll talk a little bit more about that as well. But if you look, Canagliflozin actually has the highest efficacy. So I do find when I use Canagliflozin, I get a little bit more A1C lowering than Empagliflozin. But there are those 2 additional things that you need to talk to your patients about. So first, let's talk about this rare but serious side effect just briefly, this euglycemic DKA. So in layman's terms on this, what happens is that since you're peeing out your glucose levels are normal in the blood, but you're getting acidotic. And usually a signal for the body to produce insulin, which is protective, right, from the acidosis, is high sugar. So what happens is there's sort of this disconnect and this dehydration cycle that continues, and so you get this euglycemic DKA, okay? But is it rare? Yes. So when you look at, some of the larger trials that have been done in the sodium glucose cotransporter inhibitors, the risk of DKA is less than 1%. And so how do I counsel people? Well, this is a medication actually there's a lot of debate on because There's actually a study ongoing saying that it may be protective, in the COVID patient, but a lot of people are saying potentially because of this rare risk of euglycemic DKA to not start it during the COVID time in case people develop COVID. How I look at it is that I tell people if they get a gastroenteritis, if they develop a viral illness or COVID, they should stop this medication because of the risk of dehydration and euglycemic DKA. But I am still prescribing this medication because of all the other beneficial things of it. And I actually haven't had a case of euglycemic DKA just by, counseling people when to hold the medication. And then what about the risk for urinary tract infections? So, a slight increased risk, and we would worry about maybe this in our HIV population, which may be a little bit more prone to infections. But they actually did a recent meta-analysis where they looked at severe hospitalizations from urinary tract infections as opposed to other medications, and they didn't actually find an increased risk. So again, I was very timid about using the sodium glucose cotransporter inhibitors in my older, frail women worried about the urinary tract infection risk, but I haven't seen a lot of problems with the medication, and so I am using it more comfortably in an older population now. And then finally, the fracture risk from the Canagliflozin. When you looked at the pooled studies from Canvas, which is the largest studies that were done in Canagliflozin, they found that there was a slight increased fracture risk, but not in the non-pooled Canvas studies. And the physiology of how it works really doesn't explain why you have an increased risk for complications. So that's unclear. And then, when we're talking about amputation, they say lower extremity amputation, but it was primarily more of a risk for toe amputation, which is still a serious thing, but sounds a little more tolerable than a lower extremity amputation. And so again, when you looked at the pooled studies for Canvas, there was a slight increased risk for amputation, but then more recently there's been a large retrospective study that sort of looked at this risk for lower extremity amputation and has not seen it. So I do feel like because of the slight tick and maybe fracture and lower extremity amputation, it makes it harder for me to initiate Canagliflozin, but I'm very comfortable keeping people who have been on it for a long period of time. And it is something to think about if it is potentially a class effect in those that already have significant peripheral vascular disease. I still might start it because of some of its beneficial effects, but I would think about it a little bit more in someone who has significant peripheral vascular disease at baseline. So what about the use of sodium glucose cotransporters in chronic kidney disease? So what I'm telling you now is that this is for glycemic management. This was the recommendation just for glycemic management. So typically, it's not that they harm the kidneys at lower GFRs, it's just that because of their mechanism of action, they're not very effective. So the old thing was not to use most of the flozins if your GFR was less than 45. But what happened is we're now getting more data on use in lower GFRs from a cardiac and renal protective effect. So this was a recent study that came out called CREDENCE, and what it found was that even in lower GFRs, GFR less than 45, which is the typical do not use, there was a benefit from a cardiovascular and renal progression to end-stage renal disease. And so that led to the ADA updating its guidelines to say that we should consider using the sodium glucose 2 inhibitors for the prevention of kidney failure and cardiovascular events in patients with the GFR that are greater than 30, especially in those that have severe albuminuria at baseline. So definitely you might use them between 30 and 45, not so much for their glycemic benefit, but for their cardiovascular and renal benefit. And so, again, just to use Canagliflozin as an example, you would reduce the dose to 100 milligrams a day in order to use it to benefit the cardiovascular and renal risk. And so can sodium glucose 2 inhibitors be used as an adjunct for ACE and ARBs for proteinuria? And so I think that's a great question. All the study, because ACE and ARBs are such a standard of care, all the studies are being done. Most of the patients are already on ACEs and ARBs, and then this is an additional therapy. So yes, this is a benefit that's seen, in those that are on ACE and ARB already, so an additional benefit for renal protective, but a great question there. So again, we have to start thinking about these classes of medications for reasons outside of glycemic benefit. And so sodium glucose cotransporter inhibitors definitely have the strongest data on renal benefit, and then When you look at the cardiovascular outcome studies, both the GLP-1 receptor agonists and the sodium glucose cotransporters, when you look at the MACE scores, have benefit, and it looks pretty good there. But what is unique to the sodium glucose cotransporter inhibitors in those that have congestive heart failure? They decrease the events and the rates of hospitalization from congestive heart failure. And you don't see any of that benefit. It's neutral in the GLP-1 receptor agonists. So again, when you're thinking about individualizing your therapy for those candidates and thinking about GLP-1s versus sodium glucose cotransporter inhibitors, definitely I'm trying to start preferentiating using the sodium glucose cotransporters or adding them on to the GLP-1 receptor agonists in those that have depressed EFs and congestive heart failure. And finally, because I've been talking for a long time now, very sorry in advance about that, they also recently completed a study where they looked at people with and without diabetes and congestive heart failure, and you can see dapagliflozin definitely improved heart failure and hospitalizations in patients that did not have diabetes. So again, this idea of these use of these traditional diabetes medications for cardiovascular and congestive heart failure benefit. So what about the sodium glucose 2 inhibitors and liver disease? So there may be some benefit. They did MRI, so you don't have liver biopsies or anything, but they did show there is some preliminary data that the sodium glucose cotransporter inhibitors may have some benefit in the NASH patients as well. And so my summary, there is definitely a strong cardiovascular and renal benefit for patients with diabetes. There is heart failure benefit for patients with and without diabetes. And, there is a laundry list of side effects that you need to discuss with the patient, but in my clinical experience, they're very rare, and in general, they tend to be very well-tolerated medications. You do get some weight loss from them. There may be some benefit in NASH, and the negative is maybe it's not the strongest diabetes medication, so it's hard to say, okay, your A1C is 10, this is going to be my first choice, this is going to be my next choice of agent for you. And then it's also very more expensive. It's about $300 to $400 a month for the medication, but something, obviously this is an off-label use, but I found it very effective, especially in people who are Medicare and have a high deductible or high copay. You can cut it in half, right? So you can do 12 and a half of the empagliflozin because it comes in 10 and 25, and you get a nice effect from it. And then it lasts for 2 months instead of 1 month for the patient. The same thing with the Canagliflozin, 150 milligrams instead of 300, and you get that benefit from it, and it just saves the patient a little bit of money and everything. So to think about that to be in a practical standpoint. So our conclusion, some of our medications for the treatment of type 2 diabetes have cardiovascular and renal protective effects, especially in those that have known cardiovascular disease or at high cardiovascular risk. As well, weight is such a problem and is the heart of a lot of our type 2 diabetes, and so some of our newer agents do help us with our weight loss protector, but cost always is going to be a factor in these medications. And then, there are evolving data on diabetes medications for NASH and HIV and chronic liver disease. But if you notice, none of my slides had anything about HIV. I really did look to update anything in the literature on them, and I will tell you, unfortunately, there wasn't really much to add on these newer agents in the HIV population. And this is how you individualize things for your patients. I would say that potentially both these classes of medication are safe to be used in our controlled HIV population. Obviously, if they're having weight loss, cachexia, adding on an appetite suppressant medication may not be the best choice. In someone who's prone to infections, you may not want to add on the sodium glucose cotransporter inhibitors. But in general, given their mechanism of action, they should be fairly safe for use in the HIV population. So I will end there and ask if there's any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.